We'll move right along in the interest of time. Our next speaker is Harry Thomas. He began his training in the UK's NHS, but he quickly hopped over the pond and completed his residency and fellowship at MGH, and then was on the faculty of Texas A&M as a staff physician at Baylor Scott and White, where he was the director of the IBD program, and then he joined Austin Gastroenterology. He's the co-chair of the Foundation's National Patient Education Committee and a member of the Texas Society for Gastroenterology and Endoscopy's governing board, among many other positions. So please welcome Dr. Thomas.
Thank you, David, for the introduction, and also thanks to Adam for the invitation to present this evening. So a little bit of background about me, as David mentioned. I was previously in academic, multi-specialty employed practice for 3 years, where I was doing 100% IBD, working with GI fellows, building a clinical trials program. Then 7 years ago, I moved to a single specialty GI private practice, which became affiliated with a private equity platform approximately 3.5 years ago. My practice now is approximately 30% IBD, the rest being general GI. I do have industry disclosures, but they're not relevant to this talk. So broadly speaking, I'm going to be focusing on the bottom here, physician-owned practices, and also with noting, the two other major types of practice, hospital or health system-owned, and then finally insurance-owned practices, which is growing in the United States. Now, in terms of private practice, there are many different types, of course. I already alluded to the fact that practices may or may not have a financial affiliation. So there are independent practices and now increasingly private equity-backed practices, and we'll talk a little bit about that later in the presentation. You can think in terms of size, obviously solo practices are becoming fewer and far between. Small practices, large practices, and even mega practices with over 100 partners. And then in terms of employment type, generally in private practice, you would expect to start off as an associate. And then after some period of time, typically 2 to 3 years, sometimes shorter, sometimes longer, you would expect to potentially be offered partnership or shareholder status. And some practices may also have an opportunity to work as an employed physician. Broadly speaking, there are multiple market forces that are currently changing medical practice, that are threats to gastroenterologists, as well as many other specialties. So number one is reduced reimbursement. This is a chart that may be familiar to many of you. You'll see that between 2001 and 2020, there's been very little increase in physician reimbursement, shown in purple at the bottom, and adjusted for inflation, that actually corresponds to a decline in physician payment of 22% from 2001 to 2022, whereas you'll see that hospital reimbursement has certainly kept up with inflation and has gone up significantly over 20 years. So that was reduced reimbursement. The next major threat is consolidation. So we see consolidation of payers. This has led to lower contracted rates, more red tape, really limited ability to change contracts, the so-called rack rates. And then in terms of hospital systems, there's more and more consolidation there, with hospitals employing their own gastroenterologists, which is the threat to referrals for GIs in private practice. And then finally, consolidation even amongst industry vendors, leading to higher prices of drugs, devices, the things that we use on a day-to-day basis. And then finally, wage inflation and labor shortage is, a big issue, higher costs of staff employees. And then, as practice owners, also higher costs of new gastroenterologists is a major factor as well. This was actually a New York Times article from 2009 that showed that there was a shortage of about 1,000 gastroenterologists by 2020. Actually, what we have now is a shortage of over 1,600 GIs. So the shortage is actually increasing. Now, partly that's because of early COVID retirements. Obviously, GI fellowships have limited ability to increase the number of spots. And, a really amazing statistic is that 26% of GIs in this country are 65 or above. So this is a major issue. So, the impact of market threats and COVID has led to burnout. And then, this is really a threat not just for private practice, but for, GIs in general. You'll see here colonoscopy in purple, FIT testing and FOBT testing in gray, and then Cologuard testing in blue. And you can see the, dramatic increase in Cologuard, and it's now, about to overtake FIT and FOBT testing. And as the new generation of Cologuard comes out, obviously this is going to impact screening colonoscopy, which is not only the major component of private practice, but also any other practice that you look at. Yes. So I really want to thank Scott Fraser, who has published this article that gives a very nice review of consolidation of gastroenterology practice, and actually shared that last slide that I showed. He summarizes that consolidation aims to distribute those fixed costs among multiple stakeholders and simplify administrative tasks, enabling consolidated groups to remain independent and negotiate with those other increasingly consolidated entities that we talked about, such as hospital systems, insurers, pharmacy systems, and pharmacy benefits managers. This is very interesting data. You can see that in the 1980s, 76% of physicians owned their practice. That dropped to 53% by 2012, and now 44% after the height of the COVID-19 pandemic in 2022. And ownership among physicians under the age of 45 has dropped significantly. And the percentage of physicians who work in private practice has dropped just in the last 10 years from 60 to under 50%. This shows what's happening in terms of gastroenterology practice. You can see over the last 10 years or so, there has been a slight increase in the number of GI providers, but there's been actually a decrease in the number of GI practices, demonstrating the consolidation there. So why do GI groups, as well as other specialties, look to private equity? Certainly, acquiring GI practices requires significant capital, and PE groups can provide some of that capital. At this point, about 10% of all GI practices in this country have some association with private equity. How does it work? Private equity collaborates with GI groups to establish what's called an MSO, which is a management services organization, wherein the PE group manages the non-clinical responsibilities while providers, conduct, day-to-day patient care. So what are the potential advantages and disadvantages? Advantages, as we talked about, achieving economies of scale, increasing choices for patients beyond large hospital-based systems of care, where obviously costs are higher in the HOPD, hospital outpatient department setting, compared to ambulatory surgical centers. Other advantages include enhancing infrastructure to support value-based independent practice that can be responsive to their local community. And then finally, allowing practices to survive and maintain autonomy, as opposed to being part of a bigger consolidated system. And then potential disadvantages, the potential for diminished authority. So thinking about private practice in general, it is important to get an understanding of the potential revenue streams. Obviously, you all are familiar with the professional services. Those are the fee for service that we undertake, seeing patients in the clinic, performing endoscopic procedures, etc. And in private practice, there is the opportunity to derive revenue and income from ancillaries, most notably ambulatory surgical centers, ASCs, potentially also anesthesia, pathology services, infusion, pharmacy, specialty pharmacy, potentially real estate entities, and then of specific interest to individuals looking to do a lot of IBD. There is the potential to do chronic care management, CCM or PCM, research in collaboration with industry, set up potentially nutrition services, imaging, etc. So what are the major things to be thinking about as you look at private practice? So when you're looking at the initial associate job, obviously you want to understand what kind of job you're looking at. Is it outpatient, inpatient, mix of the above? What is the volume going to look like? Is it an established practice that you're joining, or you're going to be building in a new area, for example, from scratch? You want to understand the payer mix. It is important to note because some practices may have new associates go to areas with significantly different payer mix from their main location. Obviously, you'll want to know about call. I would also stress the importance of mentorship. We think about that in the academic setting, but that is important for private practice as well. You want to understand the compensation structure, which includes salary, potential bonus, and benefits, including PTO. And then really, very importantly, you want to understand what it takes to make partner or shareholder. Then thinking a little more about that associate to partnership transition, you want to understand what are the requirements to stay a partner. Some practices may have very specific criteria that you need to maintain your shareholder status. You really want to understand what opportunity you may have to participate in the ancillaries that we described earlier. You want to get some understanding of what the buy-in will look like. You want to understand if there are different types of partnership. Definitely want to know about the governance structure of the entity. Do they have a board? What are the committees? You want to understand how they measure productivity. Some groups look at RVUs, just like many academic practices. Other groups will be looking at billing. Other groups looking at collections. What's the difference between billing and collections? Billing is really agnostic to the payer mix, whereas collections really is going to depend a lot on the payer mix. So you want to get a good understanding of that. Overhead is critical and, is a big factor for academics, private practice. You want to get some understanding of what the overhead looks like. How is the ancillary income distributed amongst the different partners or types of partners? And you want to understand exactly how the endo center distributions, because obviously that's going to be a big component of your total compensation. So thinking about specific questions to ask when you're looking at groups that are already backed by a private equity group versus those that are independent. If you are looking at a group that's already part of a PE platform, you want to understand what representation the specific group that you're looking at has in the wider MSO. What kind of physician ownership there is. Does your group have representation on the MSO boards? That will really give you a clue as to how important that group is in the platform and how their views are being understood by the larger MSO. You want to talk to the assisting physicians about what their experience has been to date since the transaction with the PE group. Has their day-to-day practice changed? What has the leadership change been, if any? And then thinking about equity, you want to understand if there's an opportunity to receive plus or minus purchase additional equity in the MSO upon becoming a partner. And if so, what does the vesting schedule look like? Because obviously, if you're not able to vest for a certain number of years, that means that you'll be relatively tied to that group for that period of time. And then I would try and get an understanding of what recruitment and retention has been like following the transaction. That can really give you a good clue as to how well the group is functioning. Now, looking at the right-hand side of the slide here, what about groups that are really independent? They're not PE backed. Obviously, the number one question is how far along they may be in any conversations with PE groups. And if they are planning to join a group, what are their plans for their current and incoming associates? Because obviously that's going to have potential repercussions for them also. Other questions to ask just in general, you want to find out if a relationship with industry is permitted, if there's opportunity for education, not just with GI fellows, and certainly many private practices are involved in GI fellowship programs. Some have their own, others work in collaboration with local universities. Also, there's huge opportunity for education with advanced practice providers, APPs, find out about the group's involvement in national and state societies, and then get an understanding of how the group has been involved in service of their local community. It gives you some idea about the kind of ethos of the group. And then when to ask these questions. I think some of these questions you could potentially ask pre-visit. Most of these questions you're going to be asking on the first visit, but I would reserve some of those more detailed kind of financial type questions about partnership, perhaps to a second or subsequent visit. And then who to ask. I think it's very important to hear from different kinds of physicians in the groups that you're looking at, not just the associates who will give you a good idea of what things look like the first year or two, but then the younger partners, understand what their transition to partnership has been like, what are the challenges they're dealing with, and then the sort of older or more tenured partners. Now, what about the contract? When you're looking at the associate contract, I think it's very appropriate to have that reviewed by an attorney. Non-competes are obviously a very hot topic right now. As you know, the Federal Trade Commission banned non-competes for entities that were not affiliated with nonprofit systems. So certainly many private practices would be involved. However, that was just struck down by a judge in Texas, actually. And so that likely will be heading to higher courts and the Supreme Court in the near future. future. What else can you discuss in the associate contract? I think there's limited opportunity to negotiate. Personally, certainly you can ask about a sign-on bonus. I know some practices are actually offering stipends for fellows during their fellowship in preparation for joining the group, moving expenses. But I think a lot of the other details are largely boilerplate and will be difficult to negotiate strongly. Now, the partnership contract really is more important, but to be frank, you're going to have very limited opportunity to review that when you're first looking for a job to enter the group as an associate. Careers in private practice, as I mentioned, there are opportunities to do things other than just clinical work, be that education, research, involvement in societies, innovation, and other. I'm going to have to skip some of these slides, but I just included some slides just showing some of the things that my own partners are up to. We can just quickly flick through them, if that's okay. This is Tim Ritter up in Dallas, who was one of the lead authors on a recent study. Steve Harrison, one of my partners in San Antonio, who's the lead author on the resmetirom trial. He unfortunately just recently passed away very tragically. Rajiv Jain, also in Dallas, very involved in this IBD pregnancy care pathway that many of you will be familiar with. Two of my partners also in Dallas, very involved in fellowship education, and many of my partners highlighted here involved in our local state GI society. One of my partners here in Austin, who's leading the Practice Management Summit in Philadelphia next month. Two of my partners in Dallas and Austin, who are the ACG governors for Texas. One of my partners in Dallas who developed a Trantil, which some of you may be familiar with if you're treating some IBS in your IBD patients. Larry Kozinski, one of my partners in Chicago, who developed Sonar MD, which is a value-based healthcare app type system for patients with IBD. This was published in CGH a few years ago and was a pilot model for Blue Cross Blue Shield of Illinois. And one of my partners here in Austin, who's also a certified life coach and mentor for women physicians. So what are the key factors in successful private practice? The right climate, be it geographical climate, malpractice climate, economic climate, having a favorable payer mix, favorable contract rates, access to participate in ancillaries, and ability to change and take risks. And so in summary, I think a career in community practice has potential to be rewarding in many ways. Private practice also affords opportunities for involvement in research, education, organized medicine, and advocacy. There is the opportunity for a blended career path for people interested in privademics and really offers autonomy and flexibility that can sometimes be harder to achieve in other settings. And I think that's the end. Thank you all for your attention.